Hello, my name is Carl Wierks. I'm a board-certified, fellowship-trained orthopedic surgeon practicing at West Michigan Orthopedics in Grand Rapids, Michigan. This is a brief video discussing how much arthritis is too much for a labral repair surgery. In other videos, I have described what a labral tear of the hip is and how underlying FAI can cause the labral tear. If these injuries do not respond adequately to conservative treatments, then minimally invasive arthroscopic surgery can typically treat the labral tear and the underlying bony shape mismatch across the joint. If the joint also has underlying arthritis, however, it can decrease the benefit of the surgical repair or make it not worthwhile altogether. The question then arises, how much arthritis is too much to benefit from a labral repair surgery? Joint arthritis exists in two main forms, osteoarthritis and inflammatory arthritis. Unless there is an underlying autoimmune process, such as rheumatoid arthritis, most cases of arthritis involve osteoarthritis, so that is what I'm going to highlight in this video. The hallmark feature of osteoarthritis is breakdown and then loss of the articular or weight-bearing cartilage of the joint. The weight-bearing cartilage that we are born with both caps the ball and lines the socket of the hip joint. This allows the joint to glide smoothly. If that cartilage gets injured or starts to break down, it kicks off a cascade of inflammation that irritates the joint lining and causes further arthritic changes such as bone spurs. While an arthroscopic labral repair surgery can help repair the labral cartilage, it is unfortunately limited in that it cannot reverse arthritic damage to the weight-bearing cartilage. It is thought that the bony reshaping performed during the treatment of FAI may potentially delay or slow down the arthritic process, but cannot reverse that process altogether. Patients with early or mild arthritic changes will still seem to respond positively to joint preservations through labral repair and bone reshaping, even though the early arthritic changes cannot be treated directly. Mild arthritic changes might include clinical symptoms of mild dull or achy joint pain that is present most or all of the time. On X-rays, findings would include mild joint space narrowing, sclerosis, which is hardening of the roof of the hip socket, or small bone spurring around the joint. Clinically, on physical exam, range of motion should still be preserved, meaning similar to the other healthy hip. Moderate arthritic changes of the hip represent a gray area as to whether an arthroscopic or joint preservation procedure would be helpful. These are challenging cases because oftentimes patients with moderate hip arthritis are still relatively young and active, and as such, not ready to entertain the possibility of a hip replacement. In these scenarios, joint preservation may partially relieve the symptoms of a labral tear, but not the underlying arthritic pain. Cases of severe or advanced osteoarthritis should not be treated with hip arthroscopy. Clinically, advanced arthritis presents as a stiff, painful hip. This is confirmed on X-rays, which show complete or near complete loss of the joint space, bone spurring, and cyst formation around the joint. I do often see patients in my office who present with an MRI that shows a labral tear of the hip, but also have advanced osteoarthritis changes. These cases are best treated with a hip replacement if surgery is required. Patients often ask what happens to the labrum when we perform a hip replacement. The labrum is routinely removed whenever we perform a hip replacement because it becomes a non-functioning structure. In summary, patients with a labral tear and concomitant mild arthritic changes can still benefit from arthroscopic repair. Those with moderate arthritis can be treated on a case-by-case basis, and those with advanced osteoarthritis should be surgically treated with a hip replacement.